Good afternoon, everyone. It's my pleasure to welcome you to our webinar, PrEP for Intravenous Drug Users, Protecting Hard-to-Reach Patients. My name is Ella Rocker, and I'm very pleased to be welcoming Veronica Proper, who is our speaker for today. This webinar is taking place on November 23rd, 2023, and we are recording the webinar today so that we can share it with people who are not able to attend. This webinar is organized by the Manitoba HIV-STBBI Collective Impact Network. This is a network of innovators working collaboratively to transform the landscape of HIV and STBBIs in Manitoba. We bring people together to tackle complex HIV and STBBI systems barriers, and we seek systems change by shifting the conditions that are holding the problems in place. Today, I'm speaking to you from Treaty 1, Winnipeg, Manitoba. We acknowledge that we work and gather on the original lands of the Anishinaabe, Ojibwe, Cree, Oji-Cree, Dakota, Lakota, Inuit, and Dene peoples, and on the homeland of the Métis Nation. We are humbly working towards the Truth and Reconciliation Commission's calls for action and the missing and murdered Indigenous women and girls inquiries calls for justice through our research, events, and all of the projects of the Manitoba HIV-STBBI Collective Impact Network. If you would like to find out more about the Collective Impact Network, sign up to receive our newsletter, or find our social media and YouTube page, you can do so at cinetwork.ca. This webinar is part of our ongoing efforts to provide HIV prevention education. You can find past resources on our YouTube page. We do have a large number of people registered today, so I ask that you keep your microphone muted. We will have a question and answer period after Veronica Proper speaks today. And I ask that you type your questions into the chat today. So it's my pleasure to introduce Veronica Proper. Veronica Proper is a nurse practitioner who works with vulnerable populations in Thunder Bay, Ontario. She has experience in infectious diseases and how they intersect in those who are struggling with mental health and substance use disorders. The majority of Veronica's patients are Indigenous, and she works to provide culturally safe, trauma-informed care that focuses on client autonomy and self-determination. Veronica is the Director of Client Services at Elevate Northwestern Ontario, which is the provincially funded HIV and Hep C clinic for the region. She is one of the first nurse practitioners in the province to take on a leadership role in this space. Veronica was born with a stubborn streak to which she attributes her inability to accept that anyone can be too far gone to be helped. Together with her team at Elevate, Veronica has achieved tremendous success in engaging patients in PrEP to prevent HIV, Hep C, and HIV care. Her practice style is a mixture of evidence-based interventions, humor, and a healthy dose of profanity. So it's my pleasure to welcome Veronica today.
Thanks very much for that really kind introduction, Ella. I am honored to be here presenting my information to you today. I'm not a super formal presenter, so you may see that in some of my what I show you today. So I'm going to share my screen so you can see what I have to say. Wow. Beautiful. And then if you're not already on mute, I'll be infinitely less distracted if you can mute your microphone, but if you don't, I'll just do my best anyway. And I'm just going to hide my own face here because I don't know about you guys, but I can't look at myself while I'm doing this. It's very distracting. I worry about every time I scratch my nose. So anyway, here we go. So as Ella introduced me, I'm Veronica Proper. I am a nurse practitioner and director of client services at Elevate, which makes me sound infinitely more impressive than I actually am. I'm just a regular person who is just landed in this space where I feel the need to share what I can to try and protect as many people as I can. Let's see if I can get my screen to switch. There we go. So I always like to start off what I'm doing with a land acknowledgement. So in the spirit of truth and reconciliation, I'm going to take a moment to acknowledge the land on which we're meeting, or at least the land where my body is sitting, is the traditional territory of many nations. But I personally have the privilege of living and working on the traditional territory of the Fort William First Nation, which is signatory to the Robinson Superior Treaty of 1850. But it's not enough to just acknowledge that I'm of settler descent living on somebody else's land. Acknowledgement is meaningless without striving to be allies with Indigenous community members and to promote positive relationships moving forward. And I really hope that you can see that thread through everything that we're going to talk about today, because it's really very important to me and near and dear to my heart and the work that I'm doing. So tell me a little bit about Thunder Bay. So Thunder Bay District Health Unit declared an HIV outbreak back in 2018. And nearly everyone impacted fits into what you'd consider like a vulnerable population. The vast majority of the people impacted by this outbreak are Indigenous, younger than 30 years old, and almost all of them injection drug users. Now, Thunder Bay in particular has at least a 20% Indigenous population, although we believe that this number is likely quite a bit higher due to census undercounting. And we have a fair bit of influx from the surrounding region and lots of the remote communities. And we have lots of folks who have limited trust in healthcare providers, which is relates directly back to systemic racism and colonization, that we have lots of people who don't want to seek out healthcare because they're not confident that they're going to actually receive good care. And then to give you a little bit more of a context of what we're dealing with here, the one infectious disease specialist that we had working in the city who was taking care of people retired at the end of May in this year. So it's left a little bit of a hole, which I'm filling as best as I'm able. So this is sort of an interesting piece for me. Everybody always asks me, they're like, okay, so hold on a second. You are a nurse practitioner, and I thought that only like people who went to medical school did this kind of work, and in particular infectious disease specialists, because this stuff is really complicated, right? And you can't do anything with this without an extensive background of knowledge. And yet here we are. So during the pandemic, I got hired in the public health unit to work as a nurse practitioner doing street outreach. And while I was working during the pandemic, it became very, very clear to me that there was a lot of need in my community. So I kept coming face to face with people who were living with HIV, who were not on treatment, who were at very high risk of getting HIV, and kind of looking around going, who is helping with this equation? Who is helping these people? Why am I the only one looking around going, I think we can do more than this? When I first started doing some of this work, and I suppose the questions that I initially posed came out of being very naive as a new nurse practitioner. And I, said to my colleagues, well, like, why do we have this HIV problem in Thunder Bay? Why is this a thing? Why do we not have all these people on treatment? And the feedback that I got from people was, well, but Veronica, you can't help those people. Pardon? What do you mean? Well, you can't help those people, people who are on drugs, people who use alcohol, people who don't have a home. Their life is like not even close to consistent enough. So you just can't put them on HIV treatment. So, I mean, it just sucks, but it just is what it is. And as Ella so kindly pointed out in my introduction, I was born under a contrary star. So whenever I hear that you can't possibly do something, it just makes me want to prove you wrong. So I sort of set out with this work to go, watch me. I think you can do better for people that are living on the street and people are living with substance use disorders. And I love a good challenge. So let's see what we can do. Couple of the challenges that I came up against initially was, you don't have training to do this kind of work. So refer out. So I would refer my patients out to other healthcare providers to say, okay, well, you get them on HIV treatment then. If this stuff is so complicated, you do it. Only for me to get reports back saying, well, I can't find the patient. Well, I found my patient. He's outside the shelter on the sidewalk every single day. What do you mean you can't find him? He's there every day. Call them. No, you can't do it? Okay, fine. So basically where all of this comes from and what all of this boils down to is that I got supremely pissed off because it is just not okay to have access to healthcare, to have access to really good healthcare, and to not provide it to everybody if we can manage it. It's different if we offer it and then somebody says no, but if we don't even get as far as offering it, I got a real big problem with that. And as I said at the beginning, I'm going to talk a little bit about the thread of truth and reconciliation because it's very important to me. The very first time that I read about the stark health disparities between Indigenous and non-Indigenous people in this country, I wanted to cry, because if it doesn't make you upset to hear that Indigenous people in this country live on average 20 years less than non-Indigenous people, then the rest of this webinar is probably not going to be of interest to you, because this is the kind of thing that I'm going to keep talking about. This is the kind of stuff that really upsets me. And when I kept running into people who I could see why people were living fewer years, because they were having bearing an increased burden of disease and having fewer supports that made sense to them. That just didn't feel okay to me. So that's kind of where I came from. And now I'm going to tell you a little bit about my work in prevention, because this is my real love. Is I love public health and I love preventative work. So most of the folks that I take care of, or the people who are at super high risk, are much the same as the data that's coming out of Manitoba. Mostly we have people who are getting HIV who are IV drug users, sharing drug equipment, or they're sharing equipment and having increased sexual risk taking while they're using, sex trade workers who don't always have control over their partner, or sometimes their substance use practices. Indigenous peoples are disproportionately represented in both of these groups. And then I also have some patients who come to me that are men who have sex with men, who are not consistent in their use of condoms, and especially the receptive anal partners at a higher risk. So you came to this talk because we want to talk about preventing HIV, because HIV really is preventable. And in 2023, almost 2024, we can do one hell of a lot more than we could when HIV was first discovered. So I want to make it very, very clear that I don't think that PrEP is the only option that you should be promoting to your patients, or the only intervention that is effective, but it should be part of a host of interventions. So things that we do that help prevent HIV, which of course we know about this, but single-use harm reduction equipment. So we use the terms, unused drug paraphernalia as opposed to clean versus dirty. Barrier protection for sexual intercourse. This could be condoms, dental dams, these sorts of things. Actually treating people who do have HIV so that it reduces transmission, because once we get you undetectable, you're untransmittable, baby, and that's the goal. And then for those folks who are of particularly high risk, let's get them on PrEP and let's protect as many of them as we can. So this is a really cool diagram that I found, and I like it because it's not super complicated, because I feel like there's a lot of diagrams out there that talk about HIV and how it reproduces, and you just kind of get lost in the weeds for a little bit. So this is a very brief overview of an HIV infection. So if you get infected with HIV, it it enters your body, whether through contaminated blood or through sex, or maternal infant transmission, but we're not worried about that population as much today. HIV binds to your CD4 cell, fuses with the membrane, dumps its genetic content inside the cell, uses reverse transcriptase to make this single level the single strand RNA into a double strand of genetic material, uses its integrase enzyme to insert itself into host DNA, and then it uses the CD4 cell to replicate and produce more of itself. And now we've got these really incredible medications that can interfere with this process because we understand it so well. So I'm going to show you again how PrEP interferes, but in just a minute. So PrEP. So at this point in time, what's approved in Canada is oral medication taken once daily. And this can be either tenofovir disoproxil with a combination emtricitabine inside one tablet, or tenofovir alafenamide with emtricitabine also in the same tablet. Okay, so I will come back to the difference between those two. They're very similar, but they do have a couple of important differences. And these guys are both reverse transcriptase inhibitors. So I'm going to I'll flip my slide ahead because I can. So this is the HIV life cycle. We talked about reverse transcriptase being that enzyme that allows HIV to go from one strand of genetic material to two. And that's where PrEP it works. It's basically blocking that enzyme and saying, nah, you're not allowed to recreate that second strand copy of yourself. Forget that noise. So either tenofovir disoproxil or tenofovir alafenamide can be part of a complete HIV treatment regimen, but it's a part of the treatment regimen as opposed to the entire regimen. When taken daily, it is 99% effective, which is really, really cool because I told you earlier how much I like public health and I love preventing things. And we give vaccines that are effective, but are way less effective than that. That said, this is assuming that you have a patient who's taking their medication all the time. So if you have somebody who consistently takes their medication, it takes 7 days of being on PrEP for you to reach a therapeutic dose of the drug in your rectal tissue. So if you are, for instance, if you are the receptive anal sex partner, it would take you 7 days to build up that level of protection, that 99%. By contrast, it takes 21 days to reach this therapeutic level in vaginal tissue. So for our women, it's quite a bit longer. And right now, it's an unknown timeline to reach a therapeutic level in the bloodstream. But what I could dig up in the research for you was that it's likely very quick, but there's not been a lot of research done on it. So this is why we don't actually know, and I can't give you a quantifiable number at this time. So if you put somebody on PrEP, this is always the question I get asked is, okay, well, all right, I'm in, I put my patient on PrEP, but how do I know it's working? How do I know what am I checking for afterwards? And I'm not going to belabor this point because this is in your guidelines and you can read this stuff. But for patients who are not living a super stable life. So for me, I would consider that anybody who's substance involved, anybody who's underhoused, anybody who is just, they're struggling. They're in a struggle place in their life. And that is not meant in an unkind way, but you can just tell that things are not going well for them. I would probably have them on monthly blood work to make sure that we're keeping a very close eye on them, if they're agreeable, of course. So things that you'd want to know, you were wanting to be checking consistently for HIV serology to find out, have they been exposed to HIV? Checking to see if they have chronic hepatitis B, hepatitis C. It's probably a great time to check them for syphilis as well, because we all know that that bad boy is hanging out in our communities and wreaking havoc in many of our patients. Do a quick creatinine ALT, check on the kidney, check on the liver. Nothing too fancy here. This is pretty basic blood work. And then whenever I have somebody who's coming in for any kind of monitoring, especially if they're high risk, working sex trade or something like that, I offer what I call comprehensive STI screening. So in comprehensive STI screening, I always put it to people as, if you can have sex with this body part, we should check it to make sure that you haven't picked up an infection there. And most people respond quite well to that. So how do I get people to talk about PrEP? So I think probably the most useful thing I do in my practice is just talk to people, much like I'm talking right now, really trying to talk about things in a very kind of matter-of-fact, non-judgmental way. So these are some quotes that I've used in my practice of, some of my patients have sex to be able to pay for their drugs or for a place to sleep at night, and they worry about getting HIV. Is that something that happens to you? And most people are okay with this question because it's not being asked in a voyeuristic way. I'm not asking to tell them that I think that they're bad or that they're doing something wrong. I'm literally just asking if this is something that's part of their reality and if I need to worry about protecting them. Other times, I cannot tell you how many people I've met over the years of my practice who access sex trade workers, but they are way, way too embarrassed to admit that, or at least they're too embarrassed to admit it to me. And so if I ask somebody a question that's as direct as, do you have sex with people who take money for their services? Most people will just tell me, of course not, I would never do that. However, if I phrase the question to be more like, I've met people that sometimes have sex with people whose history they don't know that well, and that can increase their risk of getting HIV. And so for those people, I offer them PrEP, which will give them some protection, which usually allows people to ask me the question about like, oh, what's that? What's PrEP? Tell me more about that, which is a lot more comfortable than a patient having to disclose to me, oh, well, actually, I do regularly have sex with sex trade workers. And, I've actually had 3 or 4 STIs in the last year because this is my sexual practice. It doesn't require people to tell me, that, well, actually, I'm married and I'm not supposed to be having sex with anybody that I haven't, gotten married to, according to my partner. But I do anyway, right? It avoids that kind of awkward conversation or people feeling like they have to tell on themselves. Because really, for me, it's not about the morality of it. It's just about the reality of how do I protect you and how do I protect other people? So these are ways that I can do that by putting PrEP out there in a way that doesn't make people feel like they can't accept it. I also just talk to people about PrEP if they come and they request like routine STI or BBI screening from me. We're just doing the routine stuff, and just talk to them like, hey, did you know that for people who are concerned about it, we can actually give you medication that prevents HIV. Did you know that was a thing? And lots of people will tell me, they're like, what? I had no idea that was even an option available, because we've done a really great job marketing PrEP to certain populations. I mean, among the men who have sex with men population, we've done an outstanding job as a large group of medical providers at marketing to this group. But in terms of marketing it to other people, we haven't really offered that as much. So I just talk about it with everybody, because you just never know where planting the seed is going to lead the conversation. Or maybe this particular patient doesn't then ask you for PrEP or want to have a prescription done, but maybe they talk to their friend, when they're out having a drink or they're out at dinner or something about this. Did you know they actually make medication for this? And then all of a sudden, I get a new referral of somebody who goes, actually, I want to hear more about this. Tell me more about this, because I worry about it a lot. The other thing I do is I talk to people about PrEP if I'm offering any kind of harm reduction services. So if people are coming into my organization asking for, clean needles or a bio bin, or they're asking for condoms or, foil, pipes, what have you. I usually just do a very quick little soundbite about, hey, and did you know that if you're ever really worried about getting HIV, there's medicine that can help prevent that. It's as simple as that. People can take the conversation further if they like, or wave at me like I'm the crazy lady handing out harm reduction supplies out of a van or out of a clinic. It's probably not too far off the mark, but anyway. For those of you who like to be a little bit fancier is how I describe it, or a bit like to have a quantifiable number, you can use a screening tool. This is called the ARCH IDU to assess risk of HIV for those who are using intravenous drugs. I kind of break it down to these 3 questions, which are, it's not exactly how the tool is worded, but these are the main questions that I will ask people if I'm trying to figure out if PrEP is a viable option for them. So I ask people, do you use substances? I'm assuming probably likely, given the places I work, many of the folks I take care of do use substances. Do you share equipment with others? Regardless of whether that's, I only share with my girlfriend or my boyfriend or my mom or whoever, versus, I'll share with anybody. Or are you ever in places where you can't control what equipment you use? Because that's also a very different question, right? Then it's not a willful, I'm sharing equipment and I don't care, but maybe especially for my folks who end up in human trafficking situations, or who are in debt to a drug dealer, might very well end up in a place where they can't control what's happening to their own body. And so this can capture those people at that level of risk as well. So how do you keep people engaged in care? How do you keep talking to them about it? So I would say for all of the folks that I take care of, the first thing I do is work on building relationship. When I started doing this kind of work, and I started around HIV treatment, and then I kept it going further to talk about PrEP, the first thing that really struck me was so many people are resistant to talk to healthcare providers because they just have no faith that healthcare providers are there for them and are going to take good care of them. And if you are able to build trust, and if you're able to build relationship with people so that they know that that actually doesn't apply to you, then you can get a lot more done. But you have to start with the relationship. You can't start with this concept of, well, I want you to take this medication because it's going to reduce your risk of HIV. No, not especially for people who have lived through experiences of being in a residential school or a day school or Indian hospitals, or people who had family members who lived through that kind of stuff. You know, if you think back to lessons from your childhood, right? If you ever had a parent or a grandparent say to you, oh, you should never do this, or never trust this kind of person because of X, Y, or Z. You remember that kind of stuff, or many of us do anyway. People don't build trust easily. And there's been a lot of trust lost over many, many years with healthcare providers, and in particular, Indigenous populations. So you have to work on the relationship first if you're going to get anywhere. I always, when I offer people PrEP or really any medical care, I always say to them, it's a friendly offer, you know, especially if they tell me, oh no, I'm not interested in that. I just say, oh, no problem. It's a friendly offer. If you ever change your mind, you want to take me up on it, that's cool. And if you never change your mind, also cool. I'll still be here to take good care of you. Very, very important to be willing to accept that patients are going to say no. And they might say no more than once. And that's okay. It's hard though. I have to acknowledge that, because especially when you are as passionate about this work and about this type of prevention as I am, it's really hard to sit in your seat and go, man, I can see the risk for you. I can see where this life is going to take you, and I'm worried for you. And I take care of people who live with HIV. And although our treatments are very, very good, it would just be better if people didn't have to be on medication for the rest of their lives. So I get really jazzed about PrEP. I get really excited about talking about all these things. But sometimes my patients are not as excited as I am, because I've been accused of being a bit of a nerd, maybe once or twice. So I have to sometimes forcibly tell myself, no, you're going to have to accept this no right now. And if I feel that the patient is really at particularly high risk, quite often what I'll do is I'll say to them, you know, would it be okay with you? Because I'm really worried about it. And I'm just honest with people. I just tell them straight up, I'm worried about you. I know you don't want it today, but if we have this conversation again in a few months or like 6 months, can I ask again? Because I care about you. And I want to make sure that you know it's always an offer. I've never yet had one person tell me, no, you can't ask me again, especially when I couch it in that kind of language where it's, you know, we're going to talk about this in a way that's really based out of respect for you and concern for you. And then we just carry on the conversation like they didn't just tell me, no, they don't want my care. Other strategies that can be really useful: get PrEP to wherever your patient is. Do not make your patient work to get their PrEP or work to go through all these hoops to get onto PrEP. Life is way too chaotic for IV drug users to have to go through an extra step or series of steps to get PrEP. So if you've got somebody who's already attending an addiction medicine clinic, they're going to pick up methadone or Suboxone, that's a great place to have PrEP dispensed. Many of my folks ask to have it daily dispensed at the same time. If you can get permission to provide PrEP into supervised consumption sites, that's another great spot. For some people, they're in there every single day or almost every single day. And they will take their medication while they're there because the staff will just gently nudge them like, hey, this was important to you. Do you want that? Yeah, cool. I'll hand it to you. You don't? Well, okay, that's your call too. And the same with safer supply programs. We have one in Thunder Bay. And it's been very effective because people are coming in for other dosing anyway. So why not just have PrEP there at the same time? Okay, and so now you're like, well, okay, Veronica, I get you. I feel what you're saying, and it sounds like this is all a really good idea, but why isn't anybody else doing this? Why aren't we talking about this more? So I'm going to talk a little bit about all of these kind of as an overview, and then I'm going to break them down one by one. But there is a extreme lack of data, especially on this particular population, for the effectiveness of PrEP. Rationally, it makes sense, but we don't have a lot of data. I, in particular, when I was doing my research prior to doing this talk for you guys, I found one study that talked specifically about the effectiveness of PrEP in an IV drug using population. So there's lots of talk about the concerns and there's lots of talk about the challenges, but there's not a lot of people actually trying to study it in the population. There's also some concern about could we be contributing to HIV resistance, which nobody wants to do because that's just not a good thing for anybody to have to consider. I meet healthcare providers consistently who are just really uncomfortable talking about PrEP. They feel like it's the role of a specialist. They don't want to interfere. They don't want to cause any other issues. But I would argue that we need to get over ourselves and just start talking about it all the time because it's really not that complicated to do. And then there's also fear of side effects. What if something happens to my patient because I put them on this medication? So this is the one clinical trial that I was actually able to locate. And I will apologize to the author now because I probably will not say their name correctly, but I believe this is Chupanya et al. Did this study back in 2013. So this is already 10 years old. And this is a study done out of Thailand. So they had a randomized controlled trial where they recruited just over 2,400 participants. And these folks were recruited from drug treatment clinics. So people who are already on like methadone, Suboxone, stuff like that. And they were randomized to receive either tenofovir disoproxil or a placebo. If you remember earlier in the talk, we were talking about tenofovir disoproxil and how it is paired with emtricitabine. Well, in this particular study, they just used tenofovir disoproxil. So it's just one drug or a placebo, not the combination tablet, which is what we use in Canada. So this was a 5-year study. And what they found is over the course of this 5 years, they had 50 people who developed a new HIV infection. 17 of these people were in the tenofovir group, and 33 of them were in the placebo group. Lots of these folks had suboptimal adherence, as you might expect for people attending an addiction medicine clinic. We know it's a bit of a journey for people, right? It's not just, boom, I show up at the addiction clinic and I just stay there and stay engaged in care forever. There's lots of back and forth. But despite all that, Chupanya et al. Found that there was a 49% reduction in HIV cases. So it wasn't the 99% effectiveness that we're getting in a super adherent patient, but still a 49% reduction is nothing to sneeze at. Definitely worth taking notice of. So what about side effects? Because this is another thing that people get kind of tripped up on. So prior to this talk, I was looking at the Manitoba guidelines, which are not all that different from Ontario, but you guys have a really pretty like 1 or 2 pager that I am probably going to share with all my colleagues here. And the guidelines suggest using PrEP with caution for anybody who has renal disease or decreased bone density. So now here's where I let my nerd flag fly because I can. So earlier I told you that I was going to talk to you about the difference between tenofovir disoproxil versus tenofovir alafenamide. And I love this stuff. It just gets me all fired up in the morning when I get to talk about the differences. So this particular slide is showing you the progression of drug from like the gut. So literally like you swallow your tablet, it's in the gut, it dissolves, moves through the gut, gets absorbed into the bloodstream, and then makes its way to, this slide says HIV target cell. It would be a CD4 cell. So when you have tenofovir disoproxil, so this is this TDF, you take your tablet, goes into the gut, and it immediately starts distributing drug once it hits the plasma. There's lots of active drug available. So this is why the caution exists about it can cause issues for patients with renal disease, and it can compromise bone health because it's this releasing of the medication into the plasma at high levels of active drug that can, you kind of have this splashover effect. It's working on the HIV, but it's also impacting a lot of other cells. Versus the tenofovir alafenamide, which is this TAF at the bottom. What you can see is, so TAF is the prodrug, or the precursor to tenofovir disoproxil, and it isn't cleaved to its active format until it gets into that CD4 cell. So you take your TAF, or tenofovir alafenamide, it gets absorbed through the gut, you get a little bit of spillover in the plasma, but not a lot. The main activity happening is actually happening inside the CD4 cell to block HIV, which is really, really cool. How neat is technology? Anyway, and that's one way that we can get around some of that stuff. If you've got a patient with renal health problems or bone health concerns, you can get around it by prescribing them tenofovir alafenamide as opposed to the tenofovir disoproxil. And then people have been asking me, okay, but what about injectable PrEP? Because I feel like that would be a lot easier than getting my patient to take a pill every day. So yes, but so you can use cabotegravir administered intramuscularly as injectable PrEP. It's been done. It is not approved for that particular indication in Canada. And there's actually a very good reason for that. So if you were to do injectable PrEP, which at this point is off-label in Canada, but if you were to do injectable PrEP, you would want to make sure that this was somebody that you had very consistent follow-up with. And the reason is that cabotegravir, once administered intramuscularly, will remain present in the body for long periods of time. So if you were to give somebody tenofovir disoproxil or tenofovir alafenamide, although it does stay in the body for a little bit of time after you've taken a tablet, we're talking, a few days as we're seeing it start to come out of the body, as opposed to cabotegravir can remain in the body for a year. So that's okay, provided the patient doesn't come into contact with HIV, because what can happen if you have drug available in the body, but available at a very low level, not enough to suppress the virus, now we can end up developing drug-resistant HIV. And cabotegravir is an integrase inhibitor, which is one of the really, really cool and really, really effective HIV treatments available right now. And so if you lose your ability to give your patient an integrase inhibitor as part of their HIV treatment, you're really losing a very valuable tool in the arsenal. So that's why I'm not personally doing any injectable PrEP in my practice at this time. I think it's coming, and I think that there will be good options out there, but I think that this piece really has to be worked out before I would be comfortable prescribing it, especially for this particular population, because we know that consistent follow-up is just not a reality for most of these folks as long as they're still using. And then this is sort of the end, getting towards the end of my talk here, but oh crap, now my person has HIV. I tested them and yep, I was trying to avoid this, but here it is. Crap. Now what am I going to do? So this is always really upsetting for people. I've had to tell lots of people that they have HIV. It's one of my least favorite parts of my job. And almost everybody reacts really badly, like you just sucker punch them. Best thing you can do for people, if they do suddenly find out, yeah, you've got HIV, we were trying to use PrEP for whatever reason, now you have HIV, it's not over, man. Reassure people, this is not going to be the thing that kills you. If you're taking your medication, if you're following up. But most people, especially at the stage of you're just revealing the diagnosis, they're gonna need a minute, or they're gonna need a few minutes. If you're comfortable, if you do HIV treatment, switch them over. You were on PrEP, Kate. Well, we're gonna make sure that we round out that treatment regimen. So let's get you switched over to HIV treatment. If you are not comfortable, or you're going like, Veronica, that's just like that, there's too many options. I have a busy practice and I wouldn't even know where to start. Then get them to a healthcare provider who does HIV consistently. When I was looking through the Manitoba PrEP guidelines, the thing that really struck me was, if my patient has HIV, just stop PrEP immediately. Yes, you should, but you should also get them on an HIV treatment, especially if the patient is willing. And they're like, well, no, I need to like start on that medication because I don't want to end up developing AIDS. And so that, I think, is an important piece to note, that I think it's really important. If you can do a soft handoff of your client, that also is very, very helpful. Finding providers who do this kind of care who you can trust. Or this is a whole other talk that I could give to you, but it's really not that tricky to get people, if you're doing PrEP, it's not that tricky to get people switched onto an HIV treatment. Maybe you don't have the capacity to follow them forever, but we could talk about that too, about how you just pick up with them and run with it. So in summary, PrEP prevents HIV transmission. It's one tool in our arsenal. It's highly effective when your patient is adherent. It's understudied in the IV drug use population for obvious reasons. They're a tricky group to study because they're often transient and struggle to make follow-up appointments as a general group. PrEP should always be offered in conjunction with other HIV prevention tools and harm reduction equipment. And if you have concerns about your patient's bone or renal health, we're going to look at using tenofovir alafenamide, which is the product that we know gets cleaved once it's inside the cell, not outside the cell. And then the last thing that I kind of wanted to leave you with is my bottom line. It doesn't have to be perfect to be worth doing. So I feel like in our society right now, we have this concept of, well, if it's not perfect, if it's not perfectly effective all the time, then why are we even talking about it? It's just simply not good enough. But the one study that I could find to share with you about what this looks like in an IV drug using population, despite the fact that it wasn't perfect, they still had an almost 50% reduction in the number of HIV cases. So although doing something is maybe not as much fun as doing, it perfectly, it's still worth doing, even if it's not perfect. And even if you can get your patient to use PrEP for some of the time, and they still end up developing HIV, that's still potentially a period of their life that you've offered some protection for. So again, it doesn't have to be perfect to be worth doing. And so now I'm going to stop sharing my screen and I'm going to let Paula take over. I see there's a few questions in the chat. Thank you for listening to me ramble on and on.
No, that was fantastic, Veronica. Thank you so much for your presentation. We do have some questions in the chat. I'm also going to post in the chat our evaluation survey for people who are here with us today to provide feedback on this webinar. And we'll launch right into our first question here, which is about age. So is PrEP available to people who are under 18? Does anyone know if PrEP is a sexual health tool that school nurses also promote? The folks that are asking this question say it's important people know about this before sexual and drug use transmission risks occur.
Yeah, fair enough. So I don't know that there's a ton of people talking about PrEP in a pediatric population. Again, it's kind of one of those, like, it would be a hard group to study. That said, I don't see any reason why it wouldn't be effective. There are patients who are born with HIV who are put on medications like tenofovir. They're put on Biktarvy to manage their HIV infection. So I don't see why you couldn't also use PrEP in this population. It would likely be something you do on a case-by-case basis. Talking about people, if you've got a particularly high-risk youth, it very well might be an excellent idea to have this conversation with a high-risk youth. If you've got a youth who, maybe you're not going to get through to them and get them on PrEP, but maybe you can get them some information about how this is an option. Then yeah, I think it would absolutely be worth talking about. And your point about having school nurses talk about it, great. I think the more we can talk about HIV prevention, talk about it in non-stigmatizing ways, talk about it in ways that are it's just part of life. We don't have to be afraid of it. I mean, we don't really want it, but it's just part of our world right now. And how do we protect ourselves from it? What does that look like for you? What options are the most effective out there? Yeah, I think that's really, really important. And I think it's valuable for all of us to be able to talk about it and to be able to talk about sex in healthy ways. That, yeah, it's supposed to be one of the fun parts of life. So just don't pick up any unwelcome visitors on the way, because that's less fun, I find most people are pretty receptive to that kind of approach because, it's, it's just easier to relate to.
For sure. Yeah, thanks. That's great. Another question here about PrEP coverage. So speaking from your context, if you'd like to, about PrEP coverage by health insurance, and this person is asking, is it covered for groups other than men who have sex with men? And I'll just note, I posted some information about the coverage in Manitoba, and I'll also send that out to people who are registered for this workshop and include it as a link. But if you'd like to speak about your context, that would be great.
For sure. So, yeah, so the access to PrEP is a little bit different in Manitoba than it is in Ontario, because I was reading you guys have like a PrEP prescriber program, which I think is super cool. I'd like to start one in Ontario and then get all of my colleagues to join it, because I feel like I'm just like on an island of one out here going like, just prescribe the PrEP. It's not that bad, people. In terms of coverage, so coverage can be a little bit variable. Non-insured health benefit, so those who have a status card, PrEP is covered. PrEP will be covered for people, the tenofovir disoproxil or Truvada tablet formulation is what's covered by the non-insured health benefit. You have to apply for prior approval to get the tenofovir alafenamide product covered. And then even then you have to prove why. Why do you want them to pay for the more expensive product? Which I guess makes sense, although frankly, I'm the clinician and I said it was a safer product, so you should just do it. But they don't particularly like that approach, so you have to actually fill out their form. There are lots of private drug plans who will pay for PrEP. I've never seen a plan specify that the client has to be MSM. That seems very invasive to ask those kinds of questions of your plan member. But I have seen some drug plans refuse to prescribe PrEP because they see it as a lifestyle choice. So it really depends from plan to plan. People in Ontario who are covered by Ontario drug benefits, so those would be like our social assistance recipients, people who are over 65, people who are temporarily unable to work for whatever reason. Those folks are all covered by Ontario drug benefit. But again, they're covered for the tenofovir disoproxil Truvada product, not the tenofovir alafenamide.
Thanks. Yeah, it's helpful to hear about your context. Another question here coming from someone who asks about how did you or how do you overcome barriers to HIV treatment once or when someone tests positive for HIV? So asking a little bit about elaboration on when someone does test positive in that transition to HIV treatment.
Okay. I'll do my best with where I think the question is going, but if I'm off the mark, just give me some clarifying details and I'll try again. I mean, some of the barriers initially for me for HIV treatment were, what the heck do I pick? There's so many options out there. What do I even start with? And so what I did was I started doing some training courses. There's some excellent training courses that you can do. from the BC Center for Excellence in HIV and AIDS. They're free. I'm like all about the free stuff. So that's where I started with most of my training. You can start reading articles on Up to Date. You can pull out like HIV rapid start treatment guidelines. You can basically just start reading about some of this stuff and figuring out, okay, what are some of my options? Or if you want to skip to the chase, then you start finding a friend who does this kind of stuff. Or you find this crazy lady in Thunder Bay who's doing all this stuff, who can walk you through and say, okay, here's what you can expect to start with at the beginning. There are some products that you can use right off the hop with a brand new HIV diagnosis that, although in an ideal world, of course, you have all of your blood work and all of your monitoring and you know everything is perfect. And as we said at the end of the talk, it doesn't have to be perfect to be worth doing it, right? So although maybe you don't have all the baseline blood work, you get them on the friggin' meds anyway. Come on, people, get going. Like, what are we gaining by waiting? Absolutely nothing, other than maybe we feel more secure as providers, as prescribers. But I don't know. I feel pretty secure in my knowledge that this person has HIV and I really need to treat them, for Pete's sake. Let's just do that. The only real barriers I've had to getting prescriptions accepted. So there are certain methadone clinics in Ontario that only allow, their methadone doctors to prescribe other medications to their patients through their clinic. That's been a little bit of a headache. Mostly I get around it by finding pharmacists who really prefer to make money from my prescriptions and take care of their patients and just want to do this. That's about it. I also, if I come across something that's very complicated, I will e-consult an infectious disease specialist if I need to. That does not happen very often. The medications that are available now are very, very good and are very straightforward for managing, monitoring, and there's lots of good guidelines out there. So hopefully I hit the mark of your question, but if not, just ask with different details.
Thanks. Another question here about sort of more the human or social aspect of connecting with someone who has received an HIV diagnosis and just sort of that process of trying to help someone connect with another doctor or help and adhere to medication and yeah, just sort of that process of helping someone come to terms and adhere to meds who might not be willing or able to come to terms with that diagnosis or adhere to meds. And any advice or mentorship you could offer on that.
Sure. Yeah, this is another one where it can be really tough, where people like, but you have HIV and I know you need to be on medicine, my friend. Bad things are going to happen if I don't get you on medicine. Some of it goes back to what we were talking about. It's that relationship building. People can't hear anything that you have to say. What's that saying? People don't care how much you know until they know how much you care. I find that very true with this population. I also, as I said earlier in my talk, revisit the conversation. So in the early days of having somebody with a brand new HIV diagnosis, they don't get a lot of health teaching from me because they aren't able to hear it. They just hear you have HIV and it's like, they're in a tunnel all of a sudden, right? Like they're not hearing anything other than, holy shit, you just told me I have HIV. What the hell does that mean? And what am I going to do now? For people, when they're in that first moment of you have HIV, for me, that looks a lot like, my friend, you are not alone. I got you. We're going to work together. Okay. You are not going to die. This is not the end. But today, you're not ready to hear any of that from me. We're going to talk again, but I got you. Okay. And this is where having built that relationship is so, so important, right? Because so many people, especially if they end up in this population where they've been substance involved, they're working sex trade, they are underhoused or they're homeless. usually there's a reason they ended up that way, right? There's often a lot of story where people just don't have they don't have a sense that they're worthy of stuff, or they're not they don't ever get the sense that anybody cares about them, right? And so when you take the time to build relationship with them, and then when something really big does happen, it gives you the platform to stand on to go, no, I really do got you, my friend. How do we do this for you? Let's how we do this. Oh my gosh. Okay, apparently I've reached the end of my coherent speech. How do we do this for you? How do we get you on treatment? What does that look like for you? And there's lots of options out there, right? Some of my patients are willing to pick up their medication with their methadone or their Suboxone. Some of my patients, I literally have to chase. I have some folks that I knock on their door if I haven't seen them in a while. I'm just like, hey, hi, it's me. Yeah, you know why I'm here. Cool. How you doing? I'm glad you're alive. Very good. How about those meds, eh? Or I am not above petty bribery. I've got a McDonald's gift card here on my desk. And if needed, I show up with a milkshake and a Big Mac. I can get a lot of work done. Or coffee. Okay, my friend, we're going to talk about this. If we're going to keep working together, I'll make sure I'm worth hanging out with. That it's not just all doom and gloom. Hopefully that answered the question.
Thanks so much. Maybe just one more question as we're here approaching 2 o'clock. This is a question about other PrEP resources or community of practice. So the person is asking, is there a Canadian community of practice for PrEP? That may be helpful getting healthcare providers on the same page. The way that this person sees it, lack of awareness and willingness of providers is one of the biggest barriers. They're also asking about if you know about any sort of other good promotion tools, commercials, or other promotion materials that you've found have been helpful for PrEP education.
I am not aware of any Canadian community of practice, but it sounds like a good idea. And in terms of promotion, Katie has some great free promotion materials, the CATIE, some great PrEP promo stuff that I use and have used to hand out to people individually. Some of them are teeny little pamphlets that you can slide into some harm reduction supplies or hand over to somebody while you're handing them a fistful of condoms. Maybe that's just me because that's what my practice looks like. But anyway, I'm just like, here, you're getting all the goodies today, my friend. Posters on the wall. And I mean, of course, then there's just the word of mouth advertising. Veronica can't stop talking long enough to not tell you about PrEP. So you're gonna hear about it if you can still hear her voice.
That's great. I'll also send out some of those resources and the Katie link as well to everyone registered for the webinar.
Sure. I did see there was one question.
Yeah, kind of an interesting one at the end here that you might want to respond to.
Yeah, I was just thinking that. I was like, oh, just let me talk about that. And I'll be putting my email in the chat. So if anybody has questions that they really are like, I don't know, you felt like you didn't get enough of me for the last hour, you wanted to hear more, or you wanted to ask a specific question, email me anytime. I'll try and get back to you quickly. Yes, I have received pushback as a nurse practitioner in this space as opposed to a doctor. Who the hell do you think you are showing up and working in this space? I think I'm somebody who's constantly learning, who's constantly growing. But what I say to people is you can't argue with results. Over the last 2.5 years, I have systematically directed teams to seek and find and offer treatment to people living with HIV, especially hard to reach people. And I will tell you that when I started, I had 13 high risk, hard to reach people who were not on treatment. And now, as of this particular date and time, I have 12 of them on treatment and undetectable, and one of them, unfortunately, is no longer on this earth. So people think, well, you got to have all this training, you got to have all this experience, you got to give a crap, and you got to be willing to try, basically, is the thing. NPs are showing up in this space now, and we're making a big difference. There's really good meds, there's good support. I'm willing to help mentor anybody who asks, because when I started it, I basically was like, well, I'm going it alone because I'm literally just walking around my community or driving around places in my community and people telling me, oh, like, well, you just can't help those people. The hell do you mean you can't help those people? There's my patient right there living with HIV, dying on the streets. I walk by him every damn day. What do you mean you can't help? Well, how about I try? How about I offer him care that doesn't make him feel bad for having developed HIV? Or how about I just build relationships so that he gets that there's maybe a little bit of life worth living beyond where he is right now? And maybe not. Maybe he isn't interested in all that, but maybe I can at least protect him from these horrendous infections and I can prevent him from spreading this to somebody else. And that's what gets me out of bed and fired up in the morning. So thank you for the question.
Yeah, thank you. And that was Veronica just responding to a question about receiving pushback because Veronica is an NP instead of an MD. And really inspiring words. And I'm seeing a lot of folks in the chat just thanking you for your talk today. And we would also like to thank you from the Collective Impact Network for your talk and yeah, your candid information, your expertise, and your openness to share with us today and be a part of this webinar. So thank you very much. Yeah, thank you so much. And we'll send out your email address to everyone registered in these resources. And a reminder as well, if folks want to complete our evaluation, that's helpful for us to know if we're on the right track with organizing these webinars. And yeah, thank you so much, Veronica.
Yeah, thanks for having me and good luck, everybody. Take care.